Hello, everybody. It's my big pleasure to share with you the synopsis of the recently released EACTS STS guidelines for diagnosing and treating acute and chronic syndromes of the organ aorta. My big thanks go to the entire writing committee. This is how we started early in 2023 at the EACTS headquarters in Windsor. The guys involved have been from left to right: Christian Etz, Carlos Mestres, Christoph Nienaber, Tim Berger, Andreas Martens, Nimish Desai, Florian Schönhoff, Karen Kim, Alessandro Della Corte, Urania Prevenza, Edo Quintana, Ed Chen, Luca Di Marco, Santi Trimaki, Gabriele Pifaretti, Julia Dumfart, my co-chair Martin Grabenboger behind Julia, Mario Leskan, John Eleftheriadis, Chris Schlett, as well as Milan Milojevic. The ones who have not been on this pick are Bartek Grilski, Max Kreibich, as well as Victor Abayans, and also our big thanks to everybody behind the scenes in EACTS, in particular Julia, as well as you know, pictures say and illustrations say more than 1,000 words to Annie and Angela, who were instrumental in providing us with the marvelous images you will see in a second. This is how we ended. This was in Vienna shortly before the first presentation during the EACTS meeting in autumn 2023. So, you know, behind the writing committee, there are always people who are available 24/7 on 365 days. And so my particular gratitude and my particular thanks go to Tim, to Milan, as well as to my co-chair Martin. Without them, this project would not have been possible in the given time frame. So what are we talking about? We are talking a document which has 244 pages, 256 recommendations, 33 illustrations, and up to 1,000 sites. So the first issue I would like to focus upon, and eventually one of the most important messages of the entire document, is that the organ is now perceived, the aorta is now perceived as the 24th organ of the human body. We are convinced that this was a major achievement, that we reached this unanimous consensus, because, you know, at the end, medicine is a science by nature, but it's also a science by experience. And our continuing development towards the understanding of the entire aorta from the root beyond the aortic bifurcation now raised the aorta as a whole to the organ level. And we're pretty convinced that this will help the entire community to better convey the message, to have more tailwind to create the aortic centers, and at the end to raise quality of care. So quality of care needs structures, and aortic medicine has become system relevant. For instance, in particular settings, aortic medicine or aortic surgery are now up to 20 or 25% of the entire volume. And this needs centralization, this needs structures behind, and this has implications for the healthcare system. And these recommendations are meant to support individual settings to optimize their structures to provide better patient care. In order to provide better patient care, we have to speak the same language with regard to classifications, with regard to scores, as well as with regard to definitions. And let me emphasize here the TEM classification, which now sets the standard to describe acute aortic dissection. Eventually, some of you know that the TEM classification at the end derives from the TNM system in oncology. The system is now out for 78 years, and we are pretty trustful that the TEM classification will also be out for at least the next 78 years. And let me take you shortly through the details. T is the type of acute aortic dissection, which is either type A, type B, or the arch subtype, type non-A, non-B. E stands for the location of the primary entry tier, the most important component of our perception. in each and every acute aortic dissection, which can be either E0, which means non-detectable. It doesn't mean that it's not there, but it's non-detectable, or E1, any proximal tear in the root or in the ascending aorta, E2, any tear within the aortic arch, or E3, any downstream tear. And M, the metastasis of acute aortic dissection, which is malperfusion, which can be absent, M0, which can involve the coronaries, which would mean M1, which can involve the supraortic branches, which means M2, and which can involve any downstream organ, meaning spinal cord, viscerals, renals, and extremity malperfusion, in other words, M3. And there's always a distinction between radiographic malperfusion and clinical malperfusion. So in case radiographic malperfusion is present, the nomenclature is 1, 2, or 3. And if this is correlated to clinical malperfusion, we do add a small plus, which is the marker for additional clinical implications of, for instance, a true lumen collapse. And the Gerade score, which is the first available online score to predict 30-day mortalities, 30-day mortality after acute type A aortic dissection by these easily retrievable actually radiographic as well as demographic data you can see to the right. So with regard to the classifications here, we want to emphasize that the non-A, non-B subtype involve either with the primary entry tear within the aortic arch or with a retrograde IMH into the aortic arch are extremely important, is an extremely important subtype because the natural course is fundamentally different as compared to type B aortic dissection. So this distinction is decisive. With regard to the extent of disease, and with regard to the extent of the repair, we wanted to move away from semi-quantitative descriptions like limited or extensive hemiarch replacement, suggesting and proposing that now the Ishimaru zones should be used to describe extent of disease and extent of repair. So in other words, frozen elephant trunk implantation would mean aortic arch replacement, zone 0 to zone 4. And you can play these details which each and every open endovascular or hybrid procedure according to the individual scenario. We put a lot of emphasis on the aortic root as well as the ascending aorta because this is the field which involves cardiac surgeons mostly, and we put a lot of emphasis on morphology, on cuspidity, as well as the root and ascending phenotype, because, you know, these are all the details which make the difference when we recommend surgery to the individual patient, and the cuspidity, the presence or the absence of the sinotubular junction, differentiating in root and ascending phenotype, as well as the extent into the arch, make the difference at what time point to recommend which procedure. So measuring was a very important topic because in particular, when it comes to measuring dimensions in the aortic root, there was a lot of disparity how this is done. And it's very clear that the aortic wall always has to be incorporated in the measurement algorithm and that the largest diameter should be chosen, which is always sinus to sinus and not sinus to commissure. And may I also draw your attention to here that the length of the proximal thoracic aorta for the first time is part of the decision-making process. As you will all know, the monumental data by the Eleftheriadis group and also by the Taipan project out of Tübingen defined 11 centimeter as a threshold of elevated risk to develop acute type A aortic dissection. So in other words, aortas longer than 11 equal to or longer to 11 centimeters now are another brick in the wall to recommend treatment at a certain time, at a given time point to patients with proximal thoracic aortic pathology. And here you can find the summary of all recommendations addressing the aortic root and the proximal thoracic aorta. I will not bore you with the details, and you're all welcome to go through the document, which is online available on both homepages, both on the EACTS homepage as well as the STS homepage, and can be freely accessed by everybody. When it comes to thoracoabdominal treatment, also here, to speak a common language with regard to complications is fundamental. And this is also where we dedicated a lot of focus onto endoleaks after endovascular repair of any kind of aortic pathology, but in particular with regard to thoracoabdominal pathology, and also here in particular in patients receiving fenestrated or branched endovascular repair. The summary is that type 1 or the important summary is that type 1 and type 3 endoleaks have to be regarded as treatment failures, and all others are a matter of negotiation. We in detail described the stages of traumatic aortic rupture, and we focused also in detail on Commerell's diverticulum, giving clear advice when therapy is indicated and when treatment should be done. And this is harmonized and standardized by the measurements you can see to the right. Another major leap in speaking the same language was the harmonization, how to speak about temperature. As you all know, we have surface temperatures and we have core temperatures, and the most important ones are the core temperature when deciding the temperature of lower body hypothermic circulatory arrest. And so now we have the consensus that everything above 28 degrees of Celsius should be defined as mild hypothermia. Everything below 20 and 28 degrees of Celsius should be defined as moderate hypothermia, where we differentiate in high moderate between 24 and 28, and low moderate between 20 and 24. And everything below 20 should be named deep hypothermia. And this, for the first time, enables to speak the same language and will enable comparative studies on the long run, not only in one setting, but over the continents all around the globe. So with regard to the recommendations affecting cannulation and perfusion, the important things are that the right subclavian artery should be chosen as the approach of first choice in acute type A aortic dissection, and any operation on the aortic arch where lower body hypothermic circulatory arrest in combination with selective antegrade cerebral perfusion is warranted. And there was also laid particular emphasis on ischemia reperfusion injury, where a period of 10 minutes of cold reperfusion should be implemented before starting rewarming in any procedure in hypothermic circulatory arrest of the lower body. With regard to diagnosis and indications, we put a lot of effort to focus upon the correct measurements, perpendicular measurements at the given predefined segments from the level of the aortic valve to the sign of valsalva, sinotubular junction, offspring of the brachiocephalic trunk, and any downstream aortic segment. CT is the first-line diagnostic modality, and assessment of the circle of Willis in complex aortic arch surgery is something which should be considered because, as you know, there are several patients who have an interrupted circle of Willis, which definitely has an impact on the selective cerebral perfusion strategy, in particular in the few who have a disconnected left vertebral artery, in other words, a PICA connection where the brainstem and the cerebellum are not connected to the circle of Willis. We put a lot of effort into defining the modalities of diagnostics, as well as how to measure which segment in which pathology. May I draw your attention to the right, where you can see the different lengths and widths of true and false lumen and the entire aorta in patients with acute and chronic aortic dissection. And we emphasized on another important detail, which is actually the embryologic origin of the aorta. As you will know, there are three different embryological origins of the aorta, which is the secondary heart field for the sinus of Valsalva, the neural crest for the ascending aorta and the arch, and everything downstream comes from the mesoderm. And this is actually, if you get this view, you will better understand why which segment becomes diseased and why other segments are free from disease. So this aspect was another important detail we wanted to focus upon in this document. As you will have already realized, there was a slight leftward shift in indications in the aortic root as well as in the ascending aorta. And this is also true for the thoracoabdominal aorta. And this is also based on the fundamental work of the Eleftheriadis group, focusing on the natural course of the disease, which justifies this leftward shift to treat before complications develop. And this is in particular true for patients who have multisegmental thoracoabdominal aortic disease, where it can be anticipated that several steps for complete repair, be it open or endo or combined, will be necessary, where actually treatment should already be considered at a diameter below 55 millimeters if it can be anticipated that several steps will be necessary. Needless to say that we focused on each and every disease algorithm, not only disease algorithm, but treatment algorithm with its own portfolio and armamentarium of treatment modalities. We provided these flow charts for each and every type of acute aortic dissection, focusing on the TEM classification and also advising here which extent of repair should be applied according to the individual TEM scenario, where in patients with a primary entry tear in the ascending aorta, ascending and hemi-arch replacement will solve the issue in a majority of cases. Here, the details with regard to the recommendations. This is something I warmly invite you to go through within the main document. Here, the treatment algorithm for acute type B aortic dissection, where the differentiation in acute type B aortic dissection with complications, as well as acute type B aortic dissection without complications, still remains the standard. But, and here comes the important point, and this is mentioned here, there are high risk features where patients with so-called uncomplicated type B aortic dissection might well develop complications in the short run, which is usually malperfusion or retrograde type A aortic dissection, or aneurysmal formation in the long run. And by a clear morphological analysis of your CT scan, you will be able to identify these patients with high-risk features and subject them to early treatment to prevent late disease progression. Here, the recommendations for acute type B aortic dissection and the morphological criteria for high risk, as well as the clinical criteria for high risk, which are remain persistent pain, as well as uncontrollable hypertension. The same goes for acute non-A, non-B aortic dissection, which is a distinct subtype with a fundamental different natural course as compared to acute type B aortic dissection. And also here, the high-risk features being mentioned, justifying and recommending early treatment. Here, and as the landing zone in these patients, despite transposition or despite subclavian to carotid bypass, usually is small because the arch is involved. Frozen elephant trunk implantation is a mainstay of the treatment of acute non-A, non-B aortic dissection and should be in the armamentarium of the aortic center treating these patients. We focused on each and every treatment strategy: frozen elephant trunk implantation, classical elephant trunk implantation, any kind of root repair or root replacement according to the individual extent, and of course also to supra-aortic transposition enabling TEVAR, as well as total endovascular aortic arch repair, be it by fenestration or by branches. And here you can see the details of the recommendations focusing on aortic arch repair. So we are ready at the summary, and the key message of this document are that the aorta is now the 24th organ of the human body. Aortic medicine has become system relevant, and structures in the healthcare system are needed to fulfill the needs of this system-relevant situation. A harmonization of classifications, scores, and definitions is the basis to speak the same language. This goes for the TEM classification, the Garada score, the non-A, non-B arch subtype of acute aortic dissection, the description of extent of disease as well as extent of repair by the Ishimaru zones, root morphology, ascending phenotype, root phenotype, endoleaks, as well as Commerell's diverticulum. The consensus of hypothermia above 28 mild, between 20 and 28 moderate, high moderate, low moderate, and below 20 degrees deep. This classification now enables comparative studies worldwide, a better understanding of the natural course of the disease, irrespective of the segment, impacted on diameter indications: leftward shift. Aortic length in the proximal thoracic aorta is a component of the decision-making process and is here to stay. The entire armamentarium with all treatment options under one umbrella is key. So in other words, aortic centers doing the right things at the right time points in the right patients is the way to go. And at the end, this writing committee was unique and paved the way to leverage the diagnosis and the treatment of the aortic organ to the next level. Thank you.